All right, let's see if I can share my screen. All right, can you see it? Perfect. So just briefly about me, my connection to PNHP, I was with the New Hampshire branch while I was in college. So I was working with Ken Dolkart, Don Collish, and their crew for a while. But now I'm originally from Minnesota, and I was briefly with PNHP there as well. But right now I'm a master's student in Sweden. I'm a health economist. Um, I study at it's called Karolinska Institute. It's kind of Sweden's big medical university, where they do everything sort of health related for the country. And I also work part-time at the Swedish government agency that decides which um, pharmaceuticals are worth paying for in Swedish health insurance or not. So this is going to have two parts. Each one will be about 15 minutes, and we'll pause for questions after each one. The first one, I'm just going to kind of explain how the sort of the broad strokes of how it works, what we might be able to learn from it. And then after that, I'll talk about how Sweden controls drug prices and drug spending so they don't get ripped off. All right, so just the basics. There's about 10.5 million people in Sweden. So you can kind of think of it like a mid-sized state in the US, or I guess a little larger than a mid-sized state. But it's a very open access system. Most of it is publicly owned and funded through the income tax. If you think in the UK, they have what they call the beverage system. I like to joke that Sweden is kind of like a luxury-ish beverage system in that they don't. The UK sometimes get a reputation where they don't fund it well enough. Sweden a little bit less so, and yeah. But again, like I said, very open access. I'm here for 2 years, and the way they run it is that everyone with residence privileges over, if you have, residence permit for 1 year plus 1 day or more, you get a social security number. And that social security number, you get a little ID like this from the tax agency. I have one as well. And you get healthcare access funding at the same level as citizens. They don't bother with any distinctions beyond that. And even if you don't have that, of course, you can still go and get care. It just costs you somewhat more. But they're not bothering with administrative hassles or anything. They take your little number down and they see you on your way, get you the care you need. Zooming out a little bit, just to sort of how they run it. Most people think, oh, Sweden, it's a country in Europe, whoop-de-doo, it's on the map, there it is. But when you think about healthcare, what a lot of people don't realize is that it's in some ways it's similar to the US in that they kind of have a federal system. They divide the country up into all these little, they call them regions. They used to be called counties, but I think it's most appropriate to kind of think of them as states within Sweden, these little mini states. The way I like to explain it to people is, imagine a United States of New England with universal healthcare run by the states. And because of that, the US, we have our Constitution that takes great pains to divide power between, the federal government and then the states. I think it's kind of a very useful case study for us here in Sweden to sort of learn from, what works, what doesn't, what are the pluses and minuses of doing things in the way that Sweden does. So, with that in mind, there's a division of who does what. And obviously Sweden, it's part of the European Union, so the European Union kind of supersedes in a lot of ways. But healthcare is one of the areas, usually with like, energy or food safety, whatnot, you hear about. But with healthcare, they don't do quite as much. This is mostly the national government. Um, and then what's below it, of course. So for the simplest side, explanation, on the left here, I have these three little images. The national government does the money. The regions are sort of the construction workers. They take the money and they do stuff with it. And then the municipalities kind of clean up whatever the regions miss. Um, the specific things, the national government is funding stuff. They do pensions, they do housing benefits, social insurance, so they're paying for the healthcare. They have a parliament, of course. kind of like our Congress. The Regeringskansliet is kind of like their executive branch, and then they have the agencies below it. The tax agency, Skatteverket, Socialstyrelsen, which is sort of the social services agency. They kind of regulate healthcare. But it's regions, for example, Region Stockholm, where I live, is the ones they own the hospitals, they employ the doctors and the nurses and the janitors, and that they also do public transit, they do a variety of things. They're the ones doing the brunt of the work, and the municipalities kind of pick up what's missed. For example, they do nursing homes. They also do social assistance dealing with, homelessness, stuff like that. They're actually pretty good with it. There's very little homelessness in Scandinavia, especially in Sweden. But the big picture here is they're allowing for variation within the country. People, if we go back here, people up all the way in the north in Norrbotten are going to want different things than the people all the way down in the south in Skåne next to Denmark, who are also going to want something different than people in the big city of Stockholm. And so, uh, obviously you have the national government that controls the money, and so they're there to prevent anything from going, too crazy off the off the rails. But at the regional level, if people want something slightly different and that makes them happy and they're getting the same, quality of services, that makes the system function smoother. And in a country like the US, where it's so big and people are so different across different regions, that's a helpful lesson, I think. Sorry for all the graphs, but it's kind of obligatory, to cover sort of the numbers of how it works. So Sweden spends currently right now, about the same as the UK, about 11% of their money on healthcare, much less than us, of course.
Thomas,
Yes,
are you able to remove that black bar on the right? It's covering up half of your graph.
black bar on the right. This thing, is it moving?
Nope.
Is it like the pictures of,
Oh, it just moved just now.
if I put it over there, is
Well, now we can't read the axis. Before we couldn't see the dots. So that's
Does that
something
work?
you can read. Oh, there, that's better. That's better.
No, I can't see any of you, but
Oh,
okay, I'll just go over this quick. Yeah, Sweden performs pretty well. They've had a fairly conservative government for the last couple years, so they don't perform quite as well as they used to. But these are still very good outcomes. They spend a lot less than most of their peers in Europe in terms of sort of percentage of their economy, and they get pretty good outcomes for that money. But again, when you have like this, I don't know if you can see my mouse, but when you have this sort of block of countries that are very similar, especially from year to year, it becomes difficult to kind of really parse out the true differences between them with sort of these aggregate um, indices that we can create. It's sausage making. It really depends on what you're putting in the sausage, but for what it's worth. My personal experiences. Um, I've only been here for a year, so I've only really used healthcare twice. The first time was I went to the dentist. Um, and both of these are completely publicly owned, operated. Um, when you talk to Swedes, they often complain about the dentist in that it costs more than most other care. And sometimes they have trouble booking appointments in a timely manner. I didn't experience that. I was able to get an appointment for a few days after I called, and I had like a 5 to 10 minute wait once I was in the office. And it felt like a spaceship when I was in it. They had the most modern, high-tech equipment I've ever seen. You give them your social security number, they plug you into the system, they can pull up all your medical records across all the different Swedish healthcare places you've been. And it was free for me, because of my age, I'm still fairly young. I was still a youth or whatever. So that was quite nice. The second one was actually just this week. I thought I had like uh, potentially fractured a bone in my foot because it was kind of swelling and it was hurting quite a bit when I was walking around. Fortunately, that was not the case. But I went to the urgent care to get it checked out. Unfortunately, kind of the way that healthcare, at least here in Sweden, works is social services in general as well. You check in, you get a little paper ticket, and you wait for them to call your name. And with healthcare, they prioritize whoever has the most severe problem in the room. So whoever has the most severe problem in the room gets seen first. So I had to wait a bit. But once I got seen, the staff was very helpful, friendly, very helpful. They sent me up to get an X-ray. And the best part is, with stuff like this, if they charge you a fee, it's a flat fee. So, it doesn't matter what care you need. If you don't really know what your problem is exactly, you don't have to worry, oh, I'm going to get this massive bill afterwards. The fee is fixed. And so for me, I didn't, maybe I needed an X-ray, maybe I needed something else. I don't know. But when I got there, they just, took care of me and made sure that I got what I needed. And the last thing I'll say from my personal experience is just I really love how healthcare can be a scary space, especially for, say, for children, for other vulnerable people. They make a really strong effort to make sure that their healthcare spaces and also just others. I've never been in a waiting room, for example, that doesn't have like a kid's playpen. They take really great care to decorate them in ways that make these spaces really warm and welcoming. This is the X-ray waiting room. This is on the elevator up to the X-ray room. Take an invisible friend with you. I don't know. I thought it was really cute. On the X-ray machine, they had these little friendly monsters taped to it. Um, you know, yeah. Let's see. The next one. Oh, come on. It's not letting me go to the next one. Oh, there we go. Um, Swedish healthcare is not perfect. So just to give you a little bit of the challenges, but before I tell you exactly what they are, um, the challenges are mainly management challenges. Sweden has a really great financing system, but the way that they sometimes use their doctors, their nurses, their hospitals sometimes are potentially not the most efficient. For example, when you go in, you tend to see a different clinician every time you go in. And so you lose the benefits that come with continuity of care. The trust that gets built, the knowledge of, if your doctor really understands your problems, what you're going through. Perhaps you're an elderly patient who has several chronic conditions, that's complicated. And so if you're seeing a different doctor every time, that can be a little annoying to have to re-explain your problem over and over again. As with many countries, coming out of the 1990s, the 2000s, or the neoliberal bent of politics at the time, there have been some sort of privatization things that have happened in Sweden. For example, this hospital here is run by a private for-profit company. And the Swedes regulate it very tightly. So the damage that happens to the health system is not, catastrophic. But for example, one of the main ways that they did this, they allowed for-profit clinics to open up to do hip and knee replacements because they were having a problem with really long waiting times for that. And so what ended up happening was, waiting times went down somewhat, but these private clinics, they just kind of ended up taking care of all the easy cases because that's what they could make the most money off of, leaving the hard ones to the public system. And the public system is who trains all the new doctors. And I don't know about you, I'm not a medical student, I'm an economist, but I would want to start with the easy cases if I don't know what I'm doing yet. And instead you're leaving them with the hard cases. That's probably not great for, the health system 20, 30 years down the line. Undermining clinical education, but the wheels have not fallen off the bus yet. So, if you look at the literature, it's very mixed, but I would say this probably wasn't a good idea. Again, yeah, waiting times, people often like to say, oh, beverage style systems, they have these awful waiting times, blah, 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 blah. No one in Sweden is dying because of wait times in the ER or in urgent care. It can be annoying, as I've experienced myself, but, once you get seen, the care, I found it to be quite good. In general, when you look at the metrics, quite good. And frankly, with the US, we don't really know how long the waiting times are because that data is generally kept secret. And so, they might look long on paper, but we don't really have anything to compare them to with the US. Um, and the last one I have here, this is the same as pretty much every country in the world. There's not enough clinicians, not enough doctors, not enough nurses, especially in, rural areas. You go up to northern Sweden, very cold, very dark in the winter. It's hard to convince people to live there if they're highly educated and they can go pretty much wherever they want and make a living. So I'm just going to pause here so I can take my screen. If there are any questions about what I've said so far, go ahead, Mackenzie.
Hi, thank you for giving this talk. It's been very, very interesting so far. I had a quick question. I think in one of the graphs you mentioned that Sweden spends a similar percentage of their GDP as the UK. Is that right? I was
Yeah.
curious how it works. I know you mentioned that they have really, really modern equipment, and I feel like I've read with the UK that they've been kind of struggling to keep their facilities up to date. And I was curious, kind of from an economist perspective, and how the numbers work out, how Sweden's been able to do that with a similar styled system and a similar percent of GDP.
So what I know about the UK is their main problem is kind of deferred maintenance things. They have these buildings that they built, a lot of times probably like the 50s and the 60s originally, when they were really building up their system after the Second World War. And, buildings don't last forever. And you have to maintain them, you have to renovate them, maybe you have to tear them down and build a new one. And that's expensive. And so a lot of times what happens when you have these big ticket projects that oh, we should do this, we should do this, they get pushed down, down, down further down the line. And you can you can choose to spend a little bit each year on little fixes that keep the wheels from falling off the bus rather than getting a new bus. And so my kind of understanding is the Brits are doing a lot of that, whereas the Swedes are more willing to say, we need to replace the hospital. Let's just do it. Um, and so, you know, from year to year, the Brits are able to do less, make less changes while keeping their budget, kind of where it was before. But the result is that now they have a bunch of, hospitals, clinics and whatnot that just really need to be replaced. And, because eventually you can only put so much duct tape on your car before it really falls apart, So it's kind of if that makes sense. Go ahead, Betty. You're muted though.
It's funny that we always compare on GDP. So if Sweden happens to have a higher cost of living and all their goods cost more, then their GDP will look elevated. Does that mean that they have more, that they can spend more because they're spending more on everything else too? Like, what's their cost of living compared to other places?
I mean, I've never lived in the UK, so I can't compare to there. In terms of my personal cost of living, I would say it's about the same as for me in the US. That being said, being a student in Europe, especially Scandinavia, you're subsidized. My rent is subsidized, uh,
Oh.
stuff like that.
Mhm.
I live in it's owned by, they have like student unions. And my apartment building is owned by this nonprofit that only rents to students, for
Mhm.
example, and my rent is subsidized compared to what non-students would pay for a similar. So with that
Mhm.
in mind, I can't exactly, but I
Mhm.
do imagine there is, some truth to what you're saying there. Yeah. The purchasing power is not exactly the same, but yeah.
Thank you.
Anything else before I move on to how not to get ripped off by drug companies?
How much did you say their population is?
10.5 million roughly.
Okay, thank you.
And with that, I will bring the slides back. All right, can you see it? Yes, no, maybe so.
We
Okay.
can.
So just to zoom out a bit, what really matters here when you're talking about drug costs is a lot of it is just the new products that are coming in. And so I just want to zoom out and compare how the US deals with new products versus how Sweden does. As the US, as you know, we have the FDA, and at least on paper, we can argue about how well they're doing right now. But on paper, they're supposed to answer the question of, okay, we have this new medicine. Is it safe? And is it effective? In Europe, they have an agency that does the same thing, the European Medicines Agency. They do it at the European Union level just because it doesn't make sense to duplicate that process. It'd be very expensive if they did across each of the member states. They do their thing. They answer that question. That's the pharmacists. That's above my pay grade. But what's more important for, at least from my perspective, is in Europe, and especially places like Sweden, they answer the second question. They have a second process here, which is, should we pay for it? Is it worth it? In the US, we kind of outsource this question to sort of the pharmacy benefit managers, which, as you know, they're private companies that insurance companies contract with to sort of, the way I like to think about it is, the grocery store coupons that you would get in the mail, at least when I was growing up. We're contracting with them to get all the coupon books and go through them and decide, make sure we're getting all the best deals on the groceries or whatever. Obviously, these are for-profit companies. And so the extent to which they really do that, like, do they really pass on their savings to the patients is pretty questionable. But in theory, that might be a good thing to have. So in Sweden, they have a government agency that does that because it's, taxpayer dollars that are paying for healthcare. We've got this government agency. It's called the Dental and Pharmaceutical Benefits Agency, which is the one that I work for. That sort of is responsible for answering this question of, all right, you have a new product. They're coming to us with an application. That's great, but should we pay for it? And through our process, we can make 3 types of decisions regarding new products. I stole these slides from my boss, so I apologize if there's any random Swedish words that he left in. But I think they're pretty clear. The first decision is just general reimbursement, which is yes, we'll pay for it. Surprise. And then, of course, we can also say no. And then the third one then is sort of restricted, which is, all right, this drug might be useful, but only for certain patients, only after they've tried something that's, is just as good theoretically on paper, but costs less. But maybe there are certain patients for which that one doesn't work. Then they can maybe use this more expensive option that has come out. In terms of where the money is going, before I go to like what a decision looks like, the vast majority of this money is going towards stuff that people are getting at the pharmacy. There's an OTC over-the-counter market, of course, and then there's a significant in-hospital, drugs that are being used in hospitals, of course, that the government subsidizes. But there's also this little yellow section here, and I think it really emphasizes why these sort of reimbursement decisions that we make are so important. Both for the Swedish government, but also for the companies that want to sell stuff, is the sort of stuff without coverage. Swedish patients are used to having their drugs paid for. They're not really willing to pay out of pocket very much for really anything healthcare related because they think that's ridiculous. And so if you are a drug company and you want to sell your product in Sweden, you can sell it at whatever price you want if you get the sort of the European version of the FDA to say that it's safe and effective. But very few people are going to buy it. And so, in order to make your numbers work out as the pharmaceutical company, you really have to compete with all the other pharmaceutical companies and create products that work better and cost less. Because when you come to us at TLV, the agency I work for, we're just going to say no to you if you don't do that. And then no one's going to buy your product. And if you're a pharma company, well, then you go bankrupt. So this is just an example of the kind of decisions that we're charged with. I'm not going to go into the sort of the math of how they do it, because we'd be here all day and that'd be really boring. But the gist of it is that with clinical trial data, you can kind of estimate sort of the health benefit a drug provides in a sort of standardized unit. And then the pharma company comes with a price that they want you to pay for it, and you kind of make a ratio. And with that ratio, you can compare the product you're looking at to all the other products on the market, and even across different, areas of medicine, and say, we have roughly this much money that we're able to spend. Um, is this product the best use of our money? It's great. We have these two likely generic medications on the market that can lower cholesterol for next to nothing. Do we want to add this extra product to the sort of the formulary and pay, this much times however many patients are using it? $14 compared to 25 cents a day is a lot more. Is this worth it? And you can compare that to, all the other medications out there that we have, already approved, that are in the pipeline, that sort of thing. Yeah. And, through this process, sometimes it can be a little controversial because, patients tend to see only their own condition. The newspapers, they'll only see their own condition. And so if we say no to something, it's, particularly, difficult condition, that's very hard, in that people don't always see the big picture of that. If we say yes to some new product that's quite expensive, and maybe it's a little bit better than stuff that's already out there, we also have to potentially take money away from other things. And so it's our job to balance, everything out there. But, when we do that, we get good results. Sweden is quite wealthy. You would expect it to have quite high drug prices as a result, but we don't. We have average drug prices roughly compared to the rest of Europe. And of course, much, much lower than the US. And we even have the lowest generic drug prices in all of Europe, which I think is quite cool, because Sweden is, Sweden also does a really good job of making the most of that, because we have a policy where, if your doctor prescribes you something, the pharmacist is required by law actually to dispense the cheapest equivalent, unless the prescribing doctor explicitly says otherwise. So as a result, you get the product you need at the lowest price, both for you as a patient, and also as, the government gets the lowest price too, because they're subsidizing you. So we get the most health for the least money. That's what I've got for you guys. I have these three little goodies if you want to learn more on your own. The European Union has this agency that does health system summaries of pretty much every country in Europe and a few outside of Europe as well. There are these giant sort of reviews that they do. So if you want to read about some particular aspect of the Swedish health system that you're interested in because of maybe the area of medicine that you're going into or whatever, it's probably in this document here, or any other country in Europe. You can do the same. This is the sort of the English webpage of the agency I work for. And then if you want to pretend to be a patient and see, well, maybe I broke my arm, how would care work for me in Sweden? You can go to this website, and see how the care process might look for you, where you might go, that sort of thing. 1177 is actually really cool. It's kind of like, if 911 is for the emergency room, 1177 is kind of like the phone-based, urgent care, primary care. You can just call them and, oh, I'm not sure what to do. Can I take care of this on my own? Should I go somewhere to seek care? Where should I go? That sort of thing. You call them, a registered nurse picks up the phone, and they help you. It's really cool. It helps people stay out of the emergency room if they don't really need it, stuff like that. But yeah, I'll stop there. I'll take down my slides and we can have any more questions you might have.
Well, thank you so much, Thomas. Yeah. Any other comments, folks?
Go ahead.
Just about the 1177 thing that you were saying at the end, I think that's really interesting. I don't know if we really have anything, I don't think we have anything centralized like that in the US. We only have like my chart and hopefully someone responds by the time you need a response. But I'm just curious like how long that's been around and if there's data from like before and after on utilization of like urgent care and emergency departments and stuff.
I think it's been around for maybe 10 years. It was something that Stockholm, because power is decentralized, regions can kind of start their own initiatives. And this was something that Region Stockholm started on their own, and then it spread throughout the rest of the country. The parliament was like, oh, this is a great idea. We're going to make sure every other region does this too. Um, and the main reason that they did that was because the keeping people out of the emergency room who don't really need it thing. I think each call costs around, it's like $10 per call in terms of what the government pays for it. Whereas, an emergency room visit is hundreds of dollars. And so on average, and so when they open this up, even though, a lot of people still go to the emergency room who probably would be better served in urgent care or primary care, they'll be seen faster, they'll get more appropriate care, that sort of thing. But just because there's this, decent but not huge portion of people who call instead and ask, where should I go? What do I need? They're able to give people directions for self-care at home, because it's a nurse answering the phone. They're qualified. And I think they even have like video call options now. So if you have like an injury or something, you can show them with your phone, which is phenomenal.
Show them
They're
your,
able to help people on the front end over the phone, where they are, when they want to be helped, rather than leaving it up to the patient who, patients will never know everything that they need to know about the health system. Healthcare will always be complicated. Um, Giving them a little helper that's convenient, quick, and easy. It just makes everything so much smoother. And they do save a lot of money as a result. I don't have the exact number off the top of my head, but if you prevent one emergency room visit and the call costs $10, you can see.
so to dig a little bit more into the drug pricing. So, does each region do its negotiations, or does the federal government negotiate with the drug companies to get their price?
Fortunately, it's the national government that does negotiations.
Okay, yeah,
With the regions up in northern Sweden, there's just so few people who live there.
yeah, they wouldn't have
They-
a long wait,
the drug
yeah.
companies wouldn't even bother talking to them.
No,
Uh,
it's interesting that Sweden has, a pretty high standard of living, so that would kind of correlate with what I was talking about earlier with the GDP. But they end up paying the average. So I don't know whether other countries aren't as good at negotiating, or like I don't know what factors go into these negotiations that they get.
I mean, not every country really negotiates, at least at the government level. It might be, private hospitals negotiating, or, nonprofit health systems negotiating, or whatever. Um, the example that I know somewhat about is would be Germany, in that they have, I guess the best way I can kind of think of it is it's kind of like if everyone had Obamacare insurance through these exchanges, but it's super, super highly regulated so that the prices are not stupidly insane. Um, the result is that you have lots of insurance nonprofit. I'm pretty sure they're all nonprofit. Um, Insurance entities negotiating for drug prices. The result is that if you want like a newer product, like a new drug that treats a rare condition or whatever, you're more likely to be able to get it in Germany than you are in someplace like Sweden. But the
Oh,
Germans spend more overall because they haven't consolidated their, negotiating power and said, we're going to band together to make sure you don't rip us off. You know,
mhm,
so there's some trade-offs there,
mhm.
but
Now, Zachary, you had looked at Germany. Do you remember anything about negotiating? Do any of you remember with your different countries how the drugs prices were negotiated? or whether they were negotiated.
I knew that they had a very similar setup to Sweden in that they have a system for evaluating what drugs they're going to include on the formularies for this like specific insurance plans based off of cost and efficacy. And if something was exorbitantly expensive and didn't provide that much of a clinical benefit, they wouldn't put it on. As for, I'd have to look at my slides. I do think, to his point, I think it might have been regionalized, that the sickness funds would be negotiating these drug prices. So
Yeah.
maybe not at each individual sickness fund, but I think for like the specific region. But let me check it really quick.
Yeah, because I think that in Germany, I don't know whether it's at the regional level, but that the sickness funds don't set the prices for what they do for an office visit. They're very tightly regulated. This is what you get to charge, and you can't charge the patient anymore, and they don't have to pay all that stuff, you know. But I don't know, like, do they also say this is what you can charge for this medication? You know, because if it's one national formulary, then there might be one national set of prices, or maybe each region has its own formulary.
Germany is also kind of somewhat like the US in that they have states, and those states are responsible for a lot of, I mean, they don't necessarily own the hospitals, but they're theoretically supposed to be the ones managing the hospitals, you know, stuff like that. I'm a little foggy on the exact details.
Yeah.
So
Yeah, I was
don't
able
quote
to
me,
see.
but you know.
Yeah, so
What's that?
the like federal level, the National Association of Sickness Funds will negotiate the price that I would assume is the highest price any sickness fund could pay. But the regional sickness funds are able to negotiate rebates directly with the pharmaceutical companies to decrease certain drugs,
Okay, there we go.
for their
Yeah.
specific region.
They
So
do a
there's
rebate that they're negotiating for rather than actually negotiating the
at the
official
federal level.
price. Yeah. Huh.
Yeah.
Okay, thank you. Thank you. Other folks have questions? There was something.
I had a little question, I guess, just about like provider payments, because it had me thinking about it with like the phone line again. Just like how much are people being paid? Are they paid on a salary scale? So if you're taking calls or taking patients in clinic, it doesn't really matter either way, or what does that look like?
I mean, I don't know off the top of my head, like the average salary for a doctor or a nurse. But what I can say is that in generally salaries in Europe, including in Scandinavia, are somewhat lower than they are in the US. But there's a lot less income inequality in that there's not as far fewer as a percentage, you know, people who are in abject poverty. But there's also, you know, there's no billionaires, you know, because we have wealth taxes and whatnot in Europe. You know, if you make that much money, they just take it away from you, and they put it back into the social services. I mean, in terms of the rest of Europe, you know, Scandinavians make more. Maybe the Germans make more than the Scandinavians in some areas, but yeah. Does that answer your question before I start rambling?
No worries. Yeah, I was just thinking like in terms of how providers are paid, like if you're incentivized to take those calls versus like maybe that doesn't pay as much, but if it's not based on like how many calls you're taking or how many patients you're seeing or what services you're offering, and you're just being paid like a
Yeah,
salary
okay. I see where you're going.
determined by, yeah.
Everyone's paid on it. They're pretty much all the clinicians in Sweden are government employees. So they're all paid
Oh.
on a salary. It's not like fee for service type stuff going on. You know, sometimes the hospitals get paid or funded through partially fee for service, partial like global budget stuff. You know, the formulas are always a bunch of shenanigans, but yeah, the people who are actually working in it are getting paid a salary, and there's not like you need to, you know, work to make enough to live on. I think in terms of like the nurses who answer the phones versus do care, I think the main advantage, the phone, like the phone line nurses, they live all over Sweden, at least the ones that answer calls in Stockholm. A lot of them live in the middle of nowhere, and they're oftentimes older. They're very experienced nurses. That's why they do them for the phone calls, because they're good at, diagnosing people. And they do it because they want the flexibility. They want to be able to live with their family, to have more time for their family. Maybe they have grandkids, stuff like that. Maybe they want to live on a farm, take care of the chickens, stuff like that. And so I don't think they necessarily make more or less money. I haven't heard that, but it's the flexibility that they're after, and that's why they attract who they attract for that line of work. Zachary?
Zachary?
This question, I guess, is similarly related to pay. And it doesn't sound like physicians are paid too much more than a normal person, is what it seems, based off of like the lack of wealth inequality. But you can correct me on that. But the main question is, are there recruiting challenges? Because there seems to be an idea in the US, if we don't pay physicians enough, no one's going to be a physician, and then no one's going to take care of us. So always interested to see if there's a physician shortage, or how
I mean, you have no shortage
recruiting to
of students wanting to be doctors, despite the fact that they don't make as much as they do in the US. Obviously, you make more than the average person, and some specialties do get paid quite well, of course, still here in Sweden. But again, it's not like astronomical to the extent that it is in the US. There's something else I was thinking of, but then I forgot what it was. Did that answer all your question?
Yeah, it's just pretty overarching if there's any
Yeah.
recruitment problems, and it sounds like there isn't.
Yeah, no, I mean, I don't think they really have problems recruiting people. It's more like they have problems recruiting them to certain locations, rural areas, northern Sweden, just because it's hard to get people to live in, places that are completely dark for 2 months of the year.
So, Thomas, you were thinking that if you have more private hospitals sucking up more of the easier cases, then that will hurt medical education. But the fact is that in a lot of hospitals, the hardest cases go to the medical education places specifically so you get to see
That's
as many
true.
usual circumstances as possible, because you could be out in that remote place and not have backup right around there, and you have to deal with that impossible case if you're the one there. So I'm
That's true.
not sure that that's that big of a problem for the medical education. There are other issues like increasing the costs and all. I really like the transparency on the drug prices. Like here, you don't know when you're walking, you have the prescription in your hand. When you walk in, you have no idea what the cost is going to be. And you may say, oh, never mind, I'm not going to fill this after they tell you the price.
Yeah.
And you don't have that there, in advance what it's going to be, and you can make that informed decision. So like here, when people say, oh, we need competition and we need to have people have skin in the game, but skin in the game, or my entire skin in the
Yeah.
game.
Yeah. No, I mean,
But
on our agency webpage, I think it's only in the Swedish one, but there's like a little page that you can look up any medication you want, down to like the package size, and see how much it costs.
That's great.
It's
That's great.
it's crazy.
And having the government say, yes, we have decided that we will pay for it because it is beneficial to have to pay that extra amount for that. So we're going to pay for it. But this one, we've said it's not worth
Yeah.
it. And so patients can say, okay, well, if they think it's not worth it, then I probably shouldn't get it either. So it takes that level of responsibility off the person who doesn't have the education to make that decision. They're just looking at their pocketbook, perhaps, of whether they can afford it. But that is hugely helpful. I really appreciate that part of the system. Kenzie?
A quick question kind of along the line of pharmacy stuff. So I know here, like in the US, sometimes it depends how much you have to pay for your prescription depending on what pharmacy you go to. And I was curious if you guys just have like one set pharmacy company, or if it's government owned, or how that works.
So I want to say, I forget how many decades ago, but certainly more than like 30 years ago, like all the pharmacies in Sweden were government owned. And I want to say maybe the 90s or 2000s, they allowed private competition in, but I believe the prices that patients pay for prescription drugs are the same regardless of what pharmacy you go to. I think where they sort of compete is on, over-the-counter stuff. If you want to buy a magazine or a snack or, I mean, it's like pharmacies in the US where you can buy all sorts of things that aren't necessarily prescription drugs as well. So as far as I know, the system works fairly well in terms of the core function of making sure that people get the prescription drugs they need at the appropriate price. Yeah.
Yeah, I suspect that in the more rural areas, they're gonna be all public because they're not gonna make enough money on that other stuff.
Exactly.
Stations to actually subsidize that.
Yeah.
But they have those negotiated prices, so even though by themselves, that individual pharmacy wouldn't have the control, the market share to negotiate a price, they'll get those good prices still, so that's great.
Exactly. I mean, the point, even if you allow private, companies into the market, it's so important to have the public option available, because it fills the gaps of areas that otherwise private companies are just not going to operate in, like those rural areas. People who live in the middle of nowhere still need drugs to treat their, their illness or whatnot, even if it's not profitable for a company to come in and sell it to them. Zachary?
Zach?
This is a question about, I know you said you had to pay like a $40 copay at your urgent care visit. Do you know what percentage of the national health expenditure is out of pocket for patients? Is it significant, or is that there's very limited things they have to pay for?
I mean, don't quote me on this, but I want to say maybe like 10-ish%, 15. It's not like the urgent care visit costs a lot more than $40 or whatever. It probably costs like, I knew at one point, they have like price lists where they say like the full cost of the visit. But the patient pays some relatively minor percentage of that. Because like you said, Betty, having the skin in the game, that stuff they came up with in the 1990s that, we have to prevent people from overusing healthcare. But, I mean, if the fees are super minor, do we, it's kind of a, do we need them? Do we not? Does it matter that we're debating about it? Kind of the question, but,
And then Germany had a similar amount of their national health expenditure that was devoted to, or that was out of pocket spending, and they have a pretty robust supplemental insurance system. Is that something that is also common in Sweden? Do they have any sort of private, like supplemental insurance? Or is
you
it?
can buy private insurance, and I think probably only here in Stockholm there are clinics that will take it because there's just it's it's a big city, there's a critical mass, but private insurance is really rare in Sweden, because the public system covers just about anything you need. Maybe I suppose if you like, I don't know, like if instead of waiting a week, you want to wait a day, maybe then if it's that important to you, maybe you'll buy private insurance. But very, very few people have private insurance, and there isn't really a perception that there's a need for that really on any large scale here.
And then I'll just clarify, the private insurance is duplicative insurance. Like it covers, they allow for sale of duplicative, like it covers everything included in the national health insurance, or is it just supplemental and that it has increased benefits? Coming out of pocket?
I'm not sure on that one.
Okay.
Yeah,
We didn't we didn't give Thomas the same list of all the things that you should do for. And so Thomas actually did an internship for the Minnesota chapter of PNHP while he was a Dartmouth undergraduate. He's never actually done ours, but he was huge.
Well, I watched all your recordings.
He watched all
That
of
one
our
year.
recordings, like it was at 22 or 23. And then he like helped us compare the two different internships and what things we might want to adapt from what they did and vice versa. So yeah, that was amazing. But he didn't actually participate in our internship and do the projects and stuff like that. And you did it for a whole semester, right? Rather than a summer, you were doing it during a semester, and that's why you couldn't actually do ours. Is that right?
Well, it was during this. It was during the spring. It was like because we were on a quarter system, so it was
Right.
like 10, 11 weeks or something.
Yeah, so it started in like April and went through June or July or something, yeah.
Yeah, roughly June, I think. But yeah, I'm giving this talk again to the Minnesota people in like 3 weeks. So you're my test guinea pigs.
Yeah, so you're giving it in 3 weeks, and Rowan already started back on Monday, so yeah, our intern schedule is very different from the Minnesota
Yeah.
intern.
Yeah.
Well, thank you so much. Does anybody else have questions for Thomas? This was super. I really appreciate it, especially the drug company part. That was good. Thank you.
And you have the slides, right? You can share if any of you want the slides. Feel free to. I think I emailed them to you, Betty.
I
So
believe
feel
I
free to
got
share
them, and I may have failed to put them up in the slide set yet, but I'll make sure
No
that
worries.
they
But
get. Great. Okay, thank you.
thanks so much.
Thank you.
So folks, we're going to be